Welcome and thank you for joining us today. We're very excited to see you all here and we're going to get started. I just have a few opening remarks. First, I want to welcome you to meeting 3 of the Person-Centered Care Stakeholder Consultation Series. The topic for today's meeting, you can see here on the slide, what are the service delivery considerations for providing integrated person-centered care for people living with or affected by HIV throughout their life course. First, a few instructions to help the meeting go smoothly for everyone. Please ask questions for the presenters using the Jamboard. The Jamboard link will be posted in the chat for the meeting. And please try to limit the use of the chat for technical issues. The slides for today's presentations will be shared with all participants and they'll also be posted on the IAS website. The Q&A and the breakout group time is really your chance to speak up, so please do so. But when you are not speaking, please try and stay on mute as much as possible. The breakout sessions this afternoon will be set up for 15 minutes. And when you're invited, please click join to join the breakout group. And if you lose signal or access to the meeting, please feel free to rejoin the session at any time. I'm just going to quickly show you the Jamboard. So this is what the Jamboard will look like when you click on the link. This is our opening page. You can navigate through all these different pages, but there's 11 pages here using these arrows up the top. You'll see there's a page for each of our presenters today, and this is where you can ask them a question. So grab the sticky note here and you can change the color of your sticky note and you can just say what your question is. Just type it in here. My question is whatever, and then click save and it'll add a sticky note. You can move that sticky note around if you need to make it a little bit bigger because you have a long question. You can move them around. Try not to put your sticky on top of other people's stickies. And if you accidentally move something that isn't meant to be moved, then you can just press the back arrow. So I think that's pretty self-explanatory. If you have any questions regarding the Jamboard, please also post them in the chat. A quick recap on the objectives of the stakeholder consultation series. We have 2 main objectives. The first is to provide a platform for exchange on the concept of person-centered care in the HIV response. And the second objective is to develop a joint consensus statement, including recommendations for different groups of stakeholders as they work towards realizing the full potential of person-centered care for the HIV response. This is the 3rd meeting of 5, which started in person in Montreal in July 2022 and will end in July 2023 in Brisbane at the IAS 2023 conference. Here is a quick recap of meetings 1 and 2 for those of you that weren't there, or just as a quick reminder for all of us. The first meeting was focused on setting the scene, and the key points discussed included that person-centered care must acknowledge the context of people seeking care, factors related to their identity and their complex clinical needs. Healthcare provision must be informed by client experiences and needs, be community-led and community-based, and supported by trained providers and peer navigators. And finally, that funding, targets, policies, and access to technology are key enablers for person-centered care. In our April 2023 virtual meeting, we took stock of the evidence for person-centered care. We learned that a number of person-centered care frameworks exist that address complex interactions between the person seeking care and health systems. We learned that the evidence for person-centered care within the HIV response is building, and that one size does not fit all when developing person-centered care interventions. We learned that the role of community is crucial. And it was also discussed that the level of integration of services can expand over time, and a stepwise approach to bringing in and adding on services is recommended. We learned that investment in healthcare providers is key, that this is really non-negotiable, and that the long-term success requires a focus on the changing needs of people over their life course. And finally, that stigma and discrimination are still significant barriers to the realization of person-centered care. Today, we are focusing on the practical service delivery considerations, as well as the role of client-reported outcomes and quality of life measures. We have 4 discussion questions, and these will be allocated to the breakout groups. So if you're in group 1, please focus your discussion on question 1. Group 2 on question 2, and so forth. For groups 5 and 6, please just choose 1 or 2 questions that resonate with your group the most. So this is the order of events today. We have 5 presenters who I'll let our moderators introduce, and then we will have some time for Q&A before we move into breakout groups and finish with the report backs. So now I'm pleased to introduce our moderators for today. Dr. Alan Landay is Professor and Vice Chair of the Research Department of Internal Medicine Division of Geriatrics at Rush University. He has been involved in HIV research for over 40 years. Over the past 10 years, his research focus has been on studies of the human microbiome and metabolome, and better understanding its role both in health and disease. He has extensive experience in aging-related studies and is passionate about person-centered care, especially for people growing older with HIV. Davina Kanagazabi is a Senior Technical Advisor for HIV and Viral Hepatitis with PATH, and has more than 13 years of experience providing technical management and operational support to implement high quality and efficient HIV and organizational capacity building projects over 18 countries in Africa and Asia. So over to you, Alan.
Thank you, Emma. And it's a great pleasure to be here today and to co-moderate this very important session with the IAS. It's a great pleasure to introduce our first speaker, Jules Levin, who really, there's no one better in the field to talk about the aspects of HIV and aging. Jules is one of the most tenacious AIDS activists one could ever hope to meet, and really is as passionate as anybody I know on the field. He is the executive director of the National AIDS Treatment Advocacy Project based in New York, which he founded in 1996. NATAP provides conference coverage, information, education, and advocacy globally on HIV, HCV, HBV, and related topics, including the important areas of HIV and aging. There's no one better to talk about the field than Jules. Over to you, Jules, and your presentation. Thank you.
Hi, my name is Jules Levin, a person living with HIV for 40 plus years. I'm 73 years old now, and I'm the founder and executive director of NATAP, the National AIDS Treatment Advocacy Project, based here in New York, but we do work nationally and globally, nationally in the US and globally. Our website is used globally, as well as webinars. We do 15 a year. They're mostly attended by people in the US, but some globally as well. So I'm here to talk about my experiences with aging and HIV and some of the work I've done. And I've been doing this work for a long time. I actually was the person that first recognized and discovered the problem with accelerated aging regarding comorbidities about 17 years ago, and thus was the first person to approach government officials and researchers about this to bring it to their attention. And that was, as I said, 17 years ago, when I had a meeting at the National Institutes of Health with leadership about this. And they formed a research working group, which I participated in, and they published research recommendations 17 years ago. But that really did not change at all the care and services in the clinic. And I realized that 5-6 years ago, and refocused my efforts and started a new initiative, which resulted in raising awareness amongst the patient population about 5-6 years ago, which resulted in the National HIV and AIDS Strategy for the first time having language around aging in that printed document, which started a response by the federal government to put together some responses. However, we are still in a situation where I would say 95% of people in the United States are not getting the geriatric care and screenings. People who are older, 95% of people who are over 60 getting those care and services, they're not getting them. So, I'm going to talk a little bit about my experiences. I found out I had HIV. I was probably in my mid to late 30s. And the transition through various ages up till now into my 70s has been quite a lot of different changes. Of course, going back then, the only concern was, would they find any sort of a treatment for HIV, which they did. And the first was the 3-drug regimen with a protease inhibitor, which we thought would change everything. And of course it did, but we had no idea that what would happen 30 or so or 25 years later is the realization that aging was going to be accelerated for people with HIV. And we didn't know what that would occur and what would happen. And I discovered and recognized that about, like I said, 17 years ago. And so it was only into my mid 50s when I started to realize this about 17 years ago, and saw that none of the doctors were really doing screenings and were not aware of this. And I had to put together my own network of screenings because I knew I was at risk. And I got my I got my first bone DEXA to see if I had osteoporosis, and I actually did. And the idea to do that did not come from my doctor. I had to request to get a bone DEXA. And then in discussions with my doctor back then, 15 years ago, I started a relationship with a cardiologist, which I have still today. And through the years since then, I've developed my own network of specialists. And I've developed this network myself of, I have 7 or 8 specialists in various fields, including an eye doctor, an ophthalmologist, a dentist. Dental care is extremely important. And I have a diabetes doctor. I have diabetes. I have peripheral artery disease, so I have a vascular surgeon. I have a chronic kidney disease, so I have a nephrologist, a kidney expert, and several more like that. And I have to maintain my own network and my own relationships with all these doctors, because I feel for sure if I had to leave it to my HIV clinicians, it wouldn't be done properly and I wouldn't be taking care of my health properly. So I have to be in charge of my own health. And my health has declined, particularly in the last 7 or 8 years, where excuse me, where I've developed a number of additional comorbidities, and they've gotten worse. Like, for example, my heart condition has declined, so I've had to start. Most people are aware of statins, but statins I couldn't tolerate, so I had to start Repatha, which is once every 2 week injectable to lower cholesterol and LDL. So I do that, and I've had a few. I have a few eye operations. One for a detached retina, which was successful. So as we age, and as I've aged, I've had to deal with all this. I have mobility problems. Walking and getting around have become extremely difficult for me. So that's increased, isolation. And so these are, examples of my shifting needs through the stages of my years. And I certainly didn't have these problems even in my early 60s. It was only until my late 60s and into my early 70s now that these problems started to really emerge as life-changing and life-altering in my lifestyle and my ability to perform normal daily activities. And I'm not the only person that faces all this. There are a lot of people, thousands of people facing these same problems as they age into their 70s. And we have a care structure, an HIV care structure that is not set up to deal with all this. If I had to leave what I set up, my own network of networks of experts, if I had to leave it to HIV doctors, I know for sure I would fall through the cracks. And that's why a lot of older people today are getting premature heart attacks and cancers, because I believe they're not getting the care they need. And so I've had to become not just an advocate for myself, but because I understand all of this, and I work closely with the healthcare system in the US and in New York City, I'm very acutely aware of what the problems are, what the shortfalls are, and what needs to be done. So I've become a national advocate working with local, city, state, and federal officials to try and change things. And things have changed a little bit, but they're very far from what we really need. And so it's very stressful and takes up a lot of my energy, but you know, in dealing with my HIV doctors, I have to be an expert. And sometimes they don't appreciate that I know more than them. So for example, now dealing with an issue of changing my HIV regimen and dealing with hepatitis B reactivation, if I'm not on a drug that suppresses my occult hepatitis B, that's become a new issue that I've had to educate myself about, and in turn educate my HIV doctors about, who are not really very well educated about the issue. I think what we really need here in the US, but globally, is to change the whole system of care, of HIV care for people with HIV, specifically for the aging and elderly people, and to address their needs. We need a personalized, integrated geriatric care model in HIV clinics all over the world. Here in the US, we need to change the Ryan White Care Act to do that. And in every HIV clinic in every country all over the world, they need to do that.
Thank you, Jules, for sharing your personal experience. It so deeply highlights and underscores the need to really consider life stages and transitions as a critical component of person-centered integrated HIV and health service delivery. So thank you. It is now my pleasure to introduce our next speaker, Yvette Raphael. Yvette is a co-founder of the new Advocacy for Prevention of HIV and AIDS in South Africa, and is a leader in South Africa's HIV prevention movement for young women. Yvette is one of South Africa's most influential civic leaders and human rights activists. She has spent the last 2 decades advocating for prevention education and better treatment and access to healthcare for people living with HIV, and in particular, young women and lesbian, gay, bisexual, trans, queer, and intersex communities. So over to you, Yvette.
Hi, good afternoon, and thank you so much for inviting me to this very important discussion. First, I would like to just thank the Comrade Jules over there for sharing his very important story, and one that we must always remember as people living with HIV, and I'm living with HIV myself. I would also like to apologize for the background noise. If anybody can hear that, we have a load shedding in South Africa. So one of our challenges is that. So I'm just going to quickly go through, and am I able to quickly try and take us through the Choice Manifesto, but I would also like to acknowledge my comrades and colleagues, Joyce Nyanga, as well as Navita from AVEC. So as mentioned in my introduction, one of the things that I am passionate about is advocacy for HIV prevention as for young women and girls, as well as for young women to have a choice. First of all, let's quickly have our language checked. There's a difference between options and choice. Obviously, with options, we talk about biomedical methods that are safe and effective. It requires R&D of additional options to add to the method mix. Choice is the ability for an individual to select from an array of options, and it requires policymakers, donors, governments, as well as implementers to make the mix available, accessible, as well as affordable. The introduction to the Choice Manifesto is just to let you know that the Women's HIV Prevention Choice Manifesto has been drawn up by African women in their diversity, feminists, HIV prevention advocates across Southern and Eastern Africa who are united in calling for continued political, financial support for HIV prevention choice, which includes the introduction and rollout of safe and effective options, including long-acting HIV prevention tools. So advocates and women across Africa are calling out for a choice to become available and for all the methods, especially those tested in Africa, to become available. The Choice Manifesto guiding principles is basically calling for a future free of HIV for daughters and women in Africa. As mentioned, this is drawn up by Women in Africa, an HIV prevention agenda that includes choice and multiple options for women and girls to prevent HIV as they navigate through the different stages and circumstances of their life. We know that women are not homogeneous. We go through different stages throughout our lives, and our choices for HIV prevention change as we grow older or as the women are younger. An HIV prevention agenda that will focus, invest, and prioritize the most effective population, which are adolescent girls and young women. And I think this needs no extra language or explanation, because it's clear in Africa, we are not making that change when it comes to HIV prevention for young women and girls. The prevention agenda that will put women and girls at the center and forefront for not only for research, but to access to products that are developed beyond clinical trials. An HIV prevention choice agenda that is conceptualized by community and responds to the community need. An HIV prevention agenda that follows the science and uses epidemiological evidence to make options available to women and girls who are vulnerable of HIV infection. And continued, we talk about the prioritizing key and marginalized population and scale interventions targeting them while addressing stigma and discrimination, as well as criminalization. We know that in most parts of Africa, LGBTI communities are still being criminalized, and we need to ensure that we prioritize the work that we do with them, ensure massive scale up and increased access to available HIV prevention tools and methods, and work tirelessly to ensure women have control over their health and their bodies to access a range of safe and effective options, including long-acting HIV prevention tools, such as the ring, such as the injectable Cabernet, to choose from so that they can choose what works best for them in the different times in their lives. Also prioritize systemic and non-systemic long-acting HIV biomedical HIV prevention options, and ensure, most importantly, to ensure good participatory practices and guidelines are followed. Our call to action is also continued here: adopt a human rights approach to choice, finance the choice agenda, integrate HIV prevention into already existing information and services packages, such as family planning, cervical cancer prevention, antenatal care, postnatal care, to ensure easy access and availability of of prevention methods for just adolescent girls and young women, support and prioritize and finance interventions to prevent sexually transmitted diseases amongst adolescent girls and young women who are especially vulnerable due to their anatomical makeup and cultural and traditional constraints that hinder the negotiation for safer sex. Our next step is to launch this choice manifesto, and with the leadership of the UNAIDS director, Winnie Byanyima in Uganda, with also some key partners and stakeholders of the African Women's Prevention Community Advisory Board. We call for everyone to sign on to this choice manifesto, as it will be a real game changer in the future for HIV prevention. We want to finalize dissemination plan and accompanying activities, how you can get involved. My email is there, Yvette.Raphael@APA, as well as my comrade and colleague Joyce Nyanga. And I would also like to thank our partners and sponsors and those who have shown leadership in this. And as you can see, USA, PEPFAR, the CASPER Coalition, AVAC, APA, and many African organizations that are part of this. Thank you so much.
Thank you, Yvette, for these very inspiring words on HIV prevention and your call to action in this area. I think this is tremendously important area for us to pursue clearly on a global basis, and what you've done is really inspiring. I'd like to introduce our next speaker, Helen Bygrave. Dr. Bygrave trained as a doctor in the UK and continues to work as a GP in East London. An experienced global health professional, Helen works as the NCD advisor for Médecins Sans Frontières Access Campaign and has since 2005 been providing technical support for MSF's HIV/TB projects across Africa and Asia. Outside MSF, she provides technical assistance to national ART programs worldwide and has been a driving force behind the implementation of differentiated service delivery approaches, providing technical support to the IAS differentiated service delivery program. Helen, it's a great pleasure to have you give your remarks. Thank you.
Lovely. Thanks a lot, Alan. If we can just go to the first slide. So as Alan said, I mean, I've kind of been kind of working in this field since kind of 2001, and I found myself with MSF at the time, kind of, this was probably around 2008, working in Lesotho. And it just became abundantly clear that we were not providing person-centered care. The time our services were available were not convenient to clients. We were making people come every month to the clinic, regardless if they'd been on treatment for 5 months or for 5 years. And that had real implications. It was time, it was cost, and our clinics were already at that point full with long queues, which, you know, demoralizing for healthcare workers and very difficult for the people receiving services. So next slide. So in MSF, I would say the title of this talk I was given was The Origin of Differentiated Service Delivery. And I think I want to emphasize that for me, the origin came from the people living with HIV. In our project, MSF projects in Mozambique, community art groups began to form, and they originally formed because of the demand from the people living with HIV to simplify the way we were delivering their care. So I think differentiated service delivery, as we all talk about it now, I think we have to recognize and remember that this came about because people living with HIV organized amongst themselves a way of getting their treatment in a more person-centered way for them. And then at what we've done, worked on over the last 10, 12 years or so, is trying to see how those approaches can be scaled up. Next slide. So from 2008 onwards, what we, as a response to the access challenges and the progressive kind of scale up of ART, as we increased the CD4 thresholds that we offered treatment and the numbers of people needing ART increased, we started to see these various, what we now call differentiated service delivery models emerge. So I think one of the first examples was the adherence clubs that we saw in South Africa, originally in the Eastern Cape. This is where maybe 10 to 20 people are booked at a specific time, at a specific place, often at the facility, but maybe out of the facility, to meet together, to share experiences and receive pre-packed medication. And that process can take between 30 to 60 minutes. So the adherence clubs were one of the first initiatives we started to see. And as I mentioned before, this community ART group approach, which with MSF I was involved with initially in Mozambique, and we then moved the model and adapted the model to different settings, initially in Southern and Eastern Africa. And another thing I want to point out is at the beginning of all this, in a way, this was also a response to our supply chain inadequacies. At the time, we weren't able to provide multi-month refills, but by thinking about a more person-centered approach to how we deliver the care, so allowing out-of-facility delivery, allowing in the community ART groups one person to collect medication for 6 or 7 people, we reduced the burden of the chronic disease for the patients. Because I raise this because this point often now comes up when we talk about NCDs, where we do have significant challenges in many of the countries with high HIV prevalence to provide longer NCD refills. But I say this was the case at the beginning when we started doing this, these models for ART as well. Next slide. So I've just picked this out, which from MSF's website from 2014, so nearly 10 years ago now. And we described these models at the time, not as differentiated service delivery, but as community models of care. And we talked at the time about what is patient-centered care and how these models really started to address and provide a more patient-centered approach. So I just picked that out to demonstrate that even, say at the big, 10 years ago or so, we were really kind of building this concept of differentiated service delivery around the person at the center. So adapting clinic opening times, extending or decreasing the frequency of clinical visits and extending duration of refill, and thinking about how we adapt the systems to specific patient access challenges. Next slide. And as I say, it was really kind of about in 2015, 2016, that these models started to kind of garner attention and started to be kind of recognized and scaled up by some ministries of health. And this was a document we developed with UNAIDS at the time. Again, calling it very much describing this as community-based and community-driven models of care as a response to access challenges. Next slide. So these are the kind of, I would say, the foundations of our differentiated service delivery models as we know them today. And you'll see these kind of 2 diagrams in many national guidelines now. And I just wanted to pick out, key there is the person-centeredness of how we design these models, having that at the center. On the right, we talk about the elements where we think about the clinical needs, what specific population the person is from, so a child, an adolescent, from a key population, and the specific context somebody is in, so urban, rural setting, maybe an unstable and a conflict, or high migration, high mobility setting. Once we know those 3 characteristics, then we use these building blocks of when, where, and who. So when is the frequency of services, where is the location, and who is the cadre of healthcare worker providing it, to design our service delivery model. Next slide. So 4 main models have been utilised and scaled up, really scaled up by national programmes, now in 2023. There are individual models based at facility, individual models out of facility, group models managed by healthcare workers, and group models managed by peers. These are the 4 categories of differentiated service models for people who are established on their treatment. Their viral loads are suppressed and they're doing well. But, and I want to put a big but there, next slide. I will never forget going and chatting with several community ART groups when I was in Zimbabwe. We were all congratulating ourselves that they were going, once every 3 months, or one of them was going once every 3 months to collect the group's drugs. But when you start talking to them, you find several of the group need hypertension medication. A couple of the younger women in the group needed their contraception. So in effect, these women were still going every month to collect the other chronic medicines that they needed for different conditions. So we weren't providing person-centered care. We'd sorted out the HIV part of the puzzle, but we hadn't addressed the needs of each individual person for the different diseases, the different complaints or more comorbidities that they needed care for. Next slide. So we now talk about DSD 2.0, where we want to really focus on in the next few years about how we provide better integrated care. So we can start to talk about one-stop services, integrated services for HIV, TB, family planning, non-communicable diseases. Those are the kind of the focus areas, I would say, that we see many ministries of health now starting to really kind of have a push on, so that to provide better person-centered care and reduce the number of visits each individual has to have to a facility. Next slide. There are several WHO recommendations to support this integration. There is one for TB. Next slide, you can flick through these. There is a clear recommendation for integration of sexual health, including contraception services, and for integrating diabetes and hypertension. So this is all supported by recommendations in the 2021 WHO guidance. Next slide. With the IAS, we've also developed these frameworks for the integration of TB and family planning into differentiated service delivery for HIV treatment. So the links for those frameworks are available on our website. Next slide. And it was really interesting, listening to the previous speaker talk about the challenges of aging, and what we've seen in our cohorts, and this is PEPFAR data on the right there, is that almost a fifth of our cohorts now are aging, and by nature of that, they will present more with comorbidities such as hypertension and diabetes. And I just wanted to pull out one important recommendation from WHO in their hypertension guidance, is that they do recommend less frequent visits. So a clinical visit perhaps every 6 months, with refills every 3 to 6 months. So we can start again to try and merge and integrate these non-communicable disease follow-up with our HIV follow-up. Next slide. And to flag this with Resolve to Save Lives, they've just literally, this came out on World Hypertension Day last week, developed a toolkit to really support programs to move forward with this integration. Next slide. So I'm going to stop there just to say, if you're interested to know more about differentiated service delivery, we have this website which has got lots of resources about all the different models and evidence reviews. And next slide. And we also have a free online course which you can register for free if you're interested to know more. And that includes a specific module around integration, which is so important in our conversation today around person-centered care. Thanks very much.
Thank you, Dr. Bygrave. Your presentation is just such a helpful reminder of just how far we've come along in DSD for HIV, and also for highlighting a framework for considering how we can continue to expand DSD beyond HIV and integrate other health areas as we further push towards person-centered care. So thank you. I would now like to introduce Combatende Sikombe. Combatende currently works in the research department at the Center for Infectious Disease Research in Zambia. And he focuses his research on infectious diseases, primary care, and public health. His current project is leveraging person-centered public health to improve HIV outcomes in Zambia, and previously led the Better Information for Health in Zambia project. Current research interests focus on adolescent HIV services. So I'll turn it over to you now, Combatende.
Thank you. I'll briefly put my video on so people can see me, but because of bandwidth, I'll have it switched off through the presentation, if that's okay. Thanks. So yeah, I'm sharing this work as part of a big research team that's been involved in trialing the implementation of person-centered care in Zambia, pretty much in real-world settings, and that's in 24 facilities. And so this is the outline of my presentation. I'm going to start with the current status of PCC delivery in Zambia and share some of the policy barriers of integration and the things that need to be changed for this to work at a policy level. So traditionally, HIV care and treatment has been top-down and required client compliance rather than ownership of lifelong antiretroviral therapy. Healthcare workers, often go through unexpected consequences where they're, caused by the health system or the structure, structural system of the health, or an organization. And so decisions first get made by the global community, ministers of health, etc., and then decisions are then shared with the health system. For example, donor objectives where implemented partners and governments concentrate on fulfilling targets to win additional funding or perhaps demonstrate the short-term results of investments. Unfortunately, many health systems, including Zambia, employ this method largely to decrease complexity, risk, and coordinate activities across broader programs. And so such approaches hinder person-centered care. Over time, clinical treatment and commodity supplies have been prioritized. And so, to maintain progress, the WHO advises health systems to invest in people-centered practices and communication, including ongoing training, mentoring, supportive supervision, and monitoring of healthcare workers to improve the relationships between healthcare workers and recipients of care. So, this WHO guideline recommends pretty much a bottom-up approach to quality of care where clients are engaged in their care and healthcare workers work collaboratively to ease strain, on themselves, as well as the clients by incorporating clients in their treatment plans. This bottom-up approach actually puts the healthcare work at the center of the health system, as they are the first point of contact for clients, specifically for the Zambian health system, which is primary care-based. Providers, unfortunately, in our settings, still penalize missed appointments by patients. But in countries like Zambia, we've increasingly recognized that HIV clients, like other clients, have varied personal, professional, and social situations. So this was shown by our colleague Chanda Mwamba in an article in Frontiers in Health, which basically talks about healthcare workers using their discretionary actions during visits. And something that you guys just talked to about integrating with other services. So person-centered care is new to the Zambian context and focuses on public health initiatives, largely like HIV care, which offers ART collection and adolescent-friendly treatment services and longer drug refills, as you've mentioned, through DSD models. Now, to date, the implementation of PCC approaches have happened in selected portions of the country with limited health facilities implementing the approach. PCC implementation challenges include monitoring patient experience and leveraging this data to promote quality. It's not known how to do this, but certainly what we did is we had a package where we learned how to do this and we have something that can be used. PCC, of course, requires a workforce. And of course, we've seen 6MMD rolled out in Zambia, and this has freed up healthcare worker time. But training and mentorship to introduce, establish, and sustain this person-centered care idea is really more critical in Zambia, given the availability of healthcare workers to add more services given 670. And then a gentle level incentive could also go a long way in recognizing and motivating providers to institutionalize new practices. So NGOs like CIDES have been supporting this movement through funding from PEPFAR, the Gates Foundation. And so, yeah, there's been a need to enhance health outcomes. So the MOH and implementing partners have basically shown increasing interest in PCC. For instance, there's client satisfaction tools that were recently approved for Zambia by the Ministry of Health. So quickly, I won't delve into this slide much as it was presented in the last meeting by Dr. Elvin Gen. So yeah, basically in a nutshell, healthcare worker training is important, and current treatment focuses on biomedical over psychological issues. And so healthcare worker education and limited PCC resources affect PCC implementation. And so that organizational structure is important. The socioeconomic environment is important, such as the national policy direction and the guidelines, including integration of these services. So the barriers to PCC implementation are often driven by healthcare worker staffing, as well as service provision and client support. In terms of staffing, we ought to think about whether healthcare workers are competent enough to collaborate with their clients, be it in their locality. Do they understand the language of the community and the community's preferences? And this is where the importance of that, providing that data, the client feedback mechanisms actually comes into play. The availability of staff to provide services such as referral services, referral services to different things like family planning, etc., as well as the non-communicable diseases which you guys have mentioned. In terms of the changes required at a policy level, picking on the rainbow model of integrated care, it's something that can be used to illustrate how we can integrate PCC at multiple health system levels with other priority areas, including family planning, TPT services, and NCDs. So integrated care provides better health at lower cost. At the macro level, system integration must prioritize individual requirements to satisfy population demands. System integration assumes that what is beneficial for individuals is best for the population. And then at the meso level, we require professional and organizational integration to provide continuous, comprehensive, and coordinated services to a specific population. And so this is where healthcare, the system works together with a functioning referral system and managing transfers across facilities. And then at the macro level, you want to focus on patient-provider relationships, and the clinic integration emphasizes that the person-focused viewpoint to provide ongoing care, such as data feedback systems, is used. And then just my last two slides, for PCC to be integrated into service delivery, changes have to be made at the macro level, which include leadership buy-in and commitment into PCC concept. And this is from government institutions, donor agencies, and implementing partners. Deliberate policies for funding mechanisms for PCC approaches at all levels are required. We need commitments for different components of PCC delivery. We've talked about the measurement of patient experience, the training of healthcare workers, the mentorship and incentives for them. That's something that needs to be considered. Sadly, to make these changes, international technical and financial support is required, so that this policy can be influenced. And then lastly, the policy agenda should focus on the validation of PCC tools that can be used at all levels, because there's a lack of an understanding of what this means and how it can be incorporated. And so the policymakers require this information, the implementers, the community, and the clients and healthcare workers themselves. And so clear direction from the MOH is required for integration of PCC approaches, policies to support education, resources, and mentorship. What do I mean by that? Pre-service training. If you're going to reach a number of healthcare workers, is there an accreditation system in place where people can do certain tests after they've been registered, so that PCC can be spread across the health profession? And then obviously investment in the research agenda that evaluates PCC interventions that incorporate all actors of the health system. Thank you.
Thank you, Komatende, for those really insightful remarks and how in person-centered care from the bottom-up approach and really then engaging the rest of the folks from the ministries of health and other aspects and examples from your country in Zambia. It's very insightful and I think very inspiring to see where we can take a lot of this work, and we're seeing many of the common themes across the globe in implementing person-centered care. It's a great pleasure to introduce our next speaker, An Nguyen. An is the Deputy Director for Communications and External Affairs at GLINC in Vietnam. An has over 10 years experience in outreach, healthcare package development, and demand-driven communications for persons living with HIV and target populations at high risk of HIV. At the end of 2021, An Nguyen, with his GLINC colleagues, founded GLINC Academy, a model for incubating business ideas and improving business capacity for private business in the field of HIV. He actively participated in the development of training programs, mentoring, and coaching for new startups from the target population community. An, it's a pleasure now to have you give your remarks. Thank you.
So thank you, Alan. I will share my presentation. Okay. Anyone can see my presentation?
Yes,
okay.
we can.
Hello, everyone. Yes, okay. Okay, hello everyone. I was excited for my presentation, but let's start by introducing who I am and where I come from. So my name is An and I come from Zilin, Vietnam, a 12-year-old social enterprise with over 8 years of experience in providing HIV-related health services to the key population in Vietnam. From day one, we reach people at high risk for HIV, especially men who have sex with men and transgender women. We encourage them to get tests for HIV and support them on ART if they are already infected. They were still young at that time, and after a decade, they're older. That's why I'm here today to talk about the health problem of LGBTIQI+ people with HIV when they grow old. And what do we need to prepare to deal with that problem? First, to better understand Zilin medical services, I built a timeline that includes the key milestones as you can follow on the screen. As you can see, we have several first pilot milestones. The first unit to pilot HIV live test and also HIV self-test. The first to implement PrEP, and especially the first private clinic licensed to treat HIV, which were previously only available to public health facilities. At the moment, we have 7 HIV treatment clinics in many provinces in Vietnam. We can easily open new clinics or support listeners of other community organizations who want to follow the same model. And we can also franchise the clinics, Zilin Clinic model. However, people live with HIV and any of us do not have single preoccupation with HIV. Healthcare needs more services. As such, we are preparing for the transformation into general clinic, and then possibly establishing a hospital that is LGBTIQI+ and people live with HIV friendly. Because in Vietnam, many doctors and health workers in public health facilities sometimes don't have enough knowledge about HIV and LGBT, causing many barriers to the community, even refusing to provide services. In more than 7 years since Zilin clinics were established, we have had a chain of services, as you can see. Along with that, more than 20,000 customers regularly use the service at our system. Each year, we reach more than 20,000 people at high risk of HIV infection through community education activities. We currently have more than 1,200 saved by HIV treatment in our clinic. This number continues to increase year by year. And as I said at the beginning, even people who are diagnosed with HIV when they are young, they will inevitably age. On this side, sorry. On this slide, we describe to have problem of under LGBTIQI plus people with HIV into 3 groups. The first group lie on other people without HIV. People with HIV will also face diseases such as hypertension, diabetes, cardiovascular disease. The second, less common group have problems related to the LGBTIQI plus community. It includes LGBT-related mental health issues, lack of caregiver in on sexual health, especially for gender affirming people. There are problems related to hormone use after sex reassessment surgery. And the last group are issues related to long-term use of ARVs. For example, long-term side effect potential for ARV resistant mental retardation leading to poor adherence. Just falling into one of the 3 groups, you may already feel annoyed. Meanwhile, an older LGBT with HIV, when they grow on, has. I want to emphasize this to make people realize the importance of the continuum of health care services for LGBTIQI plus people with HIV. With all of above in mind, Zealand has identified the following 4 strategies to be able to build a tailored service chain for LGBTIQI plus community living with HIV from the moment they are diagnosed with HIV until the end of their life. First, conduct community needs research and consultation with local and international experts. The second, developing the team towards the establishment to general clinics expected in 2023 towards the establishment of a hospital expected in 2025, aim to diversify in services. Thus, coordinate with local and international organizations and support agencies to test new health models and initiatives suitable for the community. And the last one, learn from practical experience and from experts to build a chain of care service best specifically for LGBTIQI plus people with HIV until the end of life. With the orientation of establishing Zealand nursing home in small distant future, the chain of healthcare services for LGBTIQI plus people with HIV from the time of diagnosis until the end of their life will contribute to ensuring that there are no gaps in our community. Instead of concluding, the information I said just now comes from a relatively new and inexperienced units in the healthcare market. However, we have the experience to grasp and capture the needs of our target clients. We know they have problems well, and we're ready to prepare for their future and also our development. Thank you for your listening. Okay, that's all my presentation.
Thank you so much, Han. I think we're at our time, actually, and we've run out of time a bit for questions and answers, it looks like, and we're ready, I believe, to move forward with our breakout session. So I'll turn this over to Davina to get us ready to move into our breakout sessions, which will go for 15 minutes, and then we'll come back with a moderated group discussion from Davina, and then final remarks from Emma. Thank you.
Great, thank you, Alan. So as Alan mentioned, we'll now go into our breakout group discussions, where each group will reflect on the presentations and experiences shared by our speakers today, and discuss service level and system and policy level considerations that are critical to advancing person-centered care. So you can find the 4 discussion questions on slides 7 through 10 of the Google Jamboard, and there's a link to the Google Jamboard and the meeting chat for those who may need it. And as Emma mentioned earlier, each breakout group will focus on one discussion questions. So groups 1 through 4 will each tackle one of the discussion questions, and groups 5 and 6, you're free to select one question to focus on. And we will reconvene after 15 minutes for each group facilitator to share a 1 to 2 minute share out from your discussions. So welcome back, everyone. I hope everyone had ample time to allow for some fruitful discussion of the questions. And so now we'll move forward with our share out. So we'll ask each facilitator to take about 1.5 to 2 minutes to share out on their discussions. And so we'll go in order of questions. So Alan, if you wouldn't mind kicking us off.
Well, I'm going to ask Axel, since it was just Axel and I in our breakout room. We had a wonderful conversation, and I'll ask Axel because I think he can give a great from his view where he is, and we talked a lot about HIV and aging. That, please, Axel.
Yeah, thank you. Well, I'm a person living with HIV more than 30 years. My focus is HIV and aging, and we hear a lot about ART. But in the situation of being aging with HIV, it's not about ART. It's about all the other aspects and what we call the comorbidities. Thus, HIV is a complex disease. And I think that in all countries, there should be more focus on prevention of comorbidities. And that should be in the delivery and in the patient-centered delivery systems. There's then we hear also during the discussion stable patients, but obviously that's a part of the population. But more and more, and it will be more and more in the future, and not only in US and Europe, but also in all the other continents, there will be more people aging and with comorbidities. And the system is not adapted to that. And obviously, time is crucial. For delivery systems, there is no time enough. But on the other way, also, I miss somewhat the enthusiasm at the physician level sometimes, because they are always focusing on the viral load and all the other aspects, but not enough on the fact that it's about accelerated aging, and comorbidities are the consequence of this. But this accelerated aging is linked to mechanisms of aging, and it's on scientific level a very interesting topic. But and not only on scientific, but I see that it's not in the mind of a lot of physicians or healthcare professionals, and also not a lot of persons living with HIV are not educated to understand that you could do something to decrease comorbidities. And one example we discussed is frailty. Before frailty, there is pre-frailty. Pre-frailty is not assessed in a lot of hospitals, and it should be assessed following the guidelines. Thus, we have a problem of translation of the guidelines to clinical practice. Thus, that's somewhat the different little topics we discussed during our face-to-face conversation.
Right. So, yeah.
Thank you, Axel and Alan. Okay, so question 2, I see 2 groups like that. So why don't we start off with Jules?
So first, let me confirm everything Axel said was really great and on target. And I wish that everybody would listen and pay attention to everything Axel said, because that was the crux of the problem globally. We need to look into the future, where we're all going to be and where some of us are now, elderly and dealing with comorbidities. And let me remind you all that besides AIDS, comorbidities are a leading cause of death for people with HIV. So to get to my group, we had 3 people plus me in our group. And the focus, the topic that the question we were supposed to address is Number two, what measures should be considered to promote person-centered care approaches? And what we talked about was each government in every region, in every area, should be funding aging initiatives. And that is, so Melvin from the Philippines talked about elderly people in HIV from a group he's working with, that he's part of, this elderly people with HIV in the Philippines, that they're putting together a list of their needs, and they're going to be submitting it to the government. And there are no services for elderly people with HIV, and they're going to be asking the government to provide these services. And then Ha from PATH in Vietnam talked about a model in Vietnam, one-stop shop model, she called it, in Vietnam, and that is a reflection, a similar model to what we have in our aging clinics here, which we have all too few of, just a little bit, which is what I think is the model of care. We need a one-stop shop model where older and aging and all people with HIV can get their personalized care needs met, including geriatric screening, as Axel said, for frailty and heart disease and mobility and physical function and bone mineral density testing. So I'm going to ask Narahi, who's a nurse, to talk about, because she got cut off, but I'm just going to mention what she did say. She talked about her patient population having neurological problems and fractures, and the relationship of those problems with ART medications, and how some of her patients have dementia and they need geriatric screenings. So Naraha, please tell us a little bit more on where you're from.
Hi, it's me again. So I am from, I was born in Salisbury, Rhodesia, now Zimbabwe, and I came into England in 1999. So I've lived in Slough and Liverpool, and I've worked in NHS hospital as well as elderly homes. And what I find out is that in referring to the topic, people in the elderly, in nursing homes, they haven't that experience of looking after people with HIV, because not so many people were going to a nursing home as this disease was still new, and as well as not having cure to cure the disease. People are still having the fear of looking or even working with someone if they know that these people have got a medical condition. They don't know how to react, and they don't know how to treat their staff who are living with HIV, I've worked in other nursing homes where you will find there is one patient who is HIV and aged, but mainly it's not that they are old, it's because they've on the way they happen to have problems like what I've said, fractures, or they're having neurological disorders, and then they end up going into nursing home that they can't look after themselves at home. So what do we do for those ones who want to stay in their own homes? How do we support them? And as well as accepting that people are different. We are from different ethnic origins. We've got our cultures, we've got our beliefs. So when we're coming in the clinic, sometimes what is seen by the other people, that HIV makes people losing their minds. People, they just think that people who are HIV, they've got mental health. Even to work in a place where, knowing that the nurse is HIV and you are working in a place, there's also stigma around that place, where if you are going to have support from other expertise who are coming from the HIV departments, coming to the other department where they don't usually see, even if they know that we do have clinics in those departments. So how do they accept the other their colleagues who are living with HIV in workplaces.
Thank you. That was,
So
yeah.
I would just like to end by summarizing. I think we all agreed that we need funding. We need global and funding. We need support from global entities, organizations, plus funding from local governments to support and fund clinics that provide patient-centered care and care for the aging and elderly. And without that funding, we're probably never going to be able to address this problem properly. We have a little bit of that going on in the United States, but it's far from enough.
Thank you both for reinforcing that important point around financing. So I'm just looking at the clock. And so for the remaining groups, I might ask each facilitator to just highlight one key takeaway that you'd like to share out from your discussions. And so Combatende, for question 2, what is sort of the one takeaway that was critical from that discussion?
Thank you. I think the one takeaway is really key populations, like we talk about person-centered care, but actually in our setting in Africa, we don't even have an opportunity to get these recipients of care in the clinic. They're getting care in private spaces. So before we can even jump towards discussing, I'm just looking at the Jamboard, discussing person-centered care, we need to get them into the clinic and be accepted. And something that came up, something that we're doing in Zambia Policy Barriers, is we talked about training of healthcare workers, be it pre-service training. And I think in Kenya, they've introduced the KP model for healthcare workers. And so the same can be done for PCC, even at accreditation as a policy level. How do you get PCC? Using continuing medical education as accreditation. Thanks.
Thank you, Combatende. So for question 3, Ty or An, what was your one main takeaway from the discussion?
Yes, so hi everyone. Ang is the key moderator, but I'm Ty from PATH. Will represent him to say in English. So we chose the question 3 about the demand generation activities and the awareness raising activities. So there are some key takeaway we have from the group discussion. The first thing is that when you have the education on sexual health and reproductive health for youth in the very early age, it will affect, it will have very positive effect to their life later then. So education to the youth will be very important. The second thing is that in Vietnam, the HIV program are very active. We have many pilot models, which are very innovative models from international to be adapted in Vietnam. And the pilot models will allow us to reach more clients and enable greater access for them to the HIV service, which is new HIV service and free. That's the second point. And the third point is that there are some religious activities we can use the light to be the platform to reach client more. You can check on the note in the blue color. Yes. And the fourth one we're talking about is about the relevant platforms. We need to choose the relevant platforms and also the right KP influencer to achieve the highest performance. For example, for the youth, we need to choose the relevant platform for them, which is very dynamic and also a very young face, for example. And for the older people, we need to have some more influencer to be more reliable or some relevant platform to them. And the last thing is to use the macro influencer on social media. They may not have too many followers, but their followers are very niche and targeted. So they can help us to get our message go viral. So that's all from our group. Thank you.
Thank you very much, Ty. And then thank you, Anna, for putting the second group 3 summary in the chat. And then we'll go over to group 4 now, and I'll turn it over to Helen.
Thanks a lot, Davina. So I was with Kate, who is specifically working on aging. So it was really great chatting with her. And we were looking at what we can learn from differentiated service delivery. And I want to frame it very much in our building blocks. And I think we talked around the who. And it was quite interesting. We talked about our experience in Canada and the UK, and obviously most of my work has been in sub-Saharan Africa. And I really wonder what high-income settings can learn from the models in sub-Saharan Africa, and the WHO, the role of primary care and the role of the GP, primary care physician, whatever it's called in your country, in terms of that coordination of care. And having a much better overview of all the patient's needs, and where appropriate, referring to the specialist. We even, dare we say, said, you know, with one pill once a day, and if your viral load is suppressed, do you need to see an HIV specialist? That might be controversial, but so we talked very much about the WHO and how that is different in many of our settings, and say that if we're not providing HIV care at primary care, which is the case for millions of people globally, it's provided by a nurse in a primary care clinic. They have extremely good outcomes in many settings. I'm not saying it's perfect by any means, but you know, if as we go further up the healthcare system, that's where we start to see more disintegration of care, yeah, and I'd say less person-centered care. And I think this is where we have to reflect the where and the who. And Kate also said something very interesting about how we separate the clinical and the non-clinical needs in terms of service providers. So the clinical needs from the psychosocial and mental health support, and how we can do that better in our settings, thinking about the who and the where as well. I don't know, Kate, if you want to chip in, because but I think we were short of time. But
thank you both, and for everyone for sharing back on those sort of thought-provoking discussion points and also calls to action. And so Emma, I'll turn it over to you to close us out.
Great. Thank you so much, everyone. It's been a really, really good discussion. I can see everyone's really got engaged with it. And we're very much looking forward to seeing you all at the next virtual session on the 22nd of June, where we will be discussing what are the core elements and mechanisms for person-centered care within the HIV response and for different stakeholders. So thank you very much to Davina and to Alan and to all our presenters today, and for everyone for their contributions to the Jamboard and the discussion. Thank you so much. Take care.